So the experience that I've had at Sydney Local Health District over the last couple of years has really been involved in clinician engagement. I'll share some education initiatives that we've had with you, some coding and documentation initiatives, and really the fundamentals of opening up the communication channels between the clinicians, the coders, and our administration. So how do you go about engaging clinicians? This is an ongoing process, and no doubt will be in years to come, but it needs to be led from above. Clinicians respect other clinicians, and you need to identify those that A, have an interest. It's a bonus if they've got some knowledge in the area, but as we've talked about, that's often limited in many areas. And they need to be respected by their peers. We've then involved them in all levels of governance, and each of our facilities has a steering committee now with senior clinician representation. We've also created departmental ABF champions. So every department within the hospital has a clinician who's responsible for knowing about activity-based funding and is the link person for activity-based funding initiatives. And hopefully with this, we'll slowly change the culture of the organisation and increase everyone's knowledge along the way. Education initiatives have started a couple of years ago, and we found that the transition from getting coders to deliver the education to doctors, to having doctors deliver it to doctors and other clinicians to other clinicians has actually improved the uptake of information. It's now part of formal hospital orientation. We present regularly at heads of department meetings, at junior clinician teaching sessions. And also the other group of people that we shouldn't forget about are the medical students. These people perform what's called a print term, so for the last 2 months before they become interns, they're in our hospital system. And these are the people that at the beginning of each year are responsible for the documentation. And as I said, they are the most junior people in the hospital with the least knowledge of this. So we really need to think about this in terms of the medical curriculum and increasing their skill levels in this area, given it's such a foundation to the activity-based funding system. We also use the internet to get regular updates because there are so many unknowns, and we get information regularly at different intervals to try and keep everyone on the same page. And we're using information technology. As I mentioned, there are over 6,000 clinicians to educate. So we're designing web-based tutorials, and knowing that the juniors, again, are often using iPhones, we're now designing an iPhone application to try and help them with their discharge summary and documentation. The other documentation initiatives have also fostered collaboration between our coders and our clinicians. So each specialty we've worked on documentation guidelines for the juniors that are on the wards, and these feed into the iPhone application. These were developed by the ABF champions in combination with the coders to work out where it is that we need to focus on our documentation. Other simple things that we've done are coders now are invited to attend department ward meetings where regular chart reviews happen. And at this time, we often encourage the juniors to do things like create an issue list once a week and to foster causation-based thinking, because they're the things in documentation that actually change the DRGs down the track. And more recently, looking forward, we're putting more emphasis on documentation as being part of the JMO review process. So it's important to them by being part of their assessment as well. Where some areas of risk have been identified in the last, particularly more recently over the last 3 months, is if you're going to put all this information, time and effort into engaging and educating clinicians, you don't then want to disengage them. And one of the things that will do this is generating data reports that shows data that's not actually correct. And we understand that the data systems are going to be imperfect, and it's going to take a while to get them right. And so we need to not make any slap decisions based on the data, particularly while we're getting it right. And we need to avoid the finger-pointing approach or blame approach where we're asking people to explain this data when in fact it wasn't correct. The other ways, we're looking at strategies to deliver more clinician-friendly reports and running education sessions for clinicians about how to interpret these reports. And there's a lot of effort going into that with our performance unit at the moment. As an educator, the other thing that we worry about is when clinicians have to balance service delivery versus other roles in the hospital, and particularly training and education. And there's a lot of focus going on to service delivery and activity and efficiency, which is benchmarked, and they're getting performance reports about. And yet something that takes a lot of time and is just as important in maintaining our workforce in the future is research and education. And yet there's no performance outcome measures. And we need to make sure that clinicians aren't being swayed away from research and education with too much focus on service delivery and outcomes.